Good afternoon, everyone. Welcome to this afternoon's plenary, where this is our Young Professionals plenary and based on diversity, equity and inclusion in paediatric palliative care. So it gives me great pleasure to introduce our first speaker, Jonathan Koffman, who is a Professor of Palliative Care and Associate Director of the Wolfson Palliative Care Research Centre at Hull York Medical School in the United Kingdom. We've asked all of our speakers this afternoon to tell us a fun fact about themselves. So Jonathan has shared that he is a self-confessed mammal. By this he means a middle-aged man in lycra and enjoys spending as much of his spare time as possible riding his bike. So apologies that the title in your programme is incorrect. Jonathan's going to speak to us this afternoon about what is the evidence we are equal at the end of life and how can we meet our core mandate. Thank you, Jonathan.
We all know who this character is. This is Dame Dr. Cicely Saunders, the original multi-professional team, started out as an almoner, then became a nurse, and then was told quite directly that if she really wanted to make a difference to patients at a really critical moment in their lives, she'd have to retrain and become a medic, which she did at St. Thomas's Hospital. Cicely was unashamedly reformist and a separatist, and we owe her an enormous debt of gratitude in terms of how she put rocket propellant into developing a multidisciplinary specialty that focused its attentions on not only physical problems, but also psychological, existential, and spiritual issues. The movement, the palliative care specialty in the United Kingdom, has grown exponentially since she started off in the early 1960s. It's grown as a specialty across the world. I think we need to applaud ourselves for that. But it's a but, and it's a big but. The benefits of palliative care haven't been shared equitably across society. There are significant population groups who still don't get value in terms of adding life to years or years to life at that point in their lives. And here I'm thinking of people from materially deprived backgrounds, people from minoritized communities, and people, for sometimes very interesting reasons, with unpredictable disease courses, which aren't akin to cancer. I was telling Sophie the other day when we were having coffee that a while back I was on a Dispatches Channel 4 program in the United Kingdom when I said that we were offering a privileged service to a social elite. And I got a phone call the next day from a chap who was the chief executive of Help the Hospices, who was incandescent with rage in relation to what I had said, and told me that he had a transcript of what I'd reported in the TV program, and that he had chairmen from up and down the country from hospices who were livid with my claim that we weren't doing right by the patients that they were serving in their populations. I was minded to think of an incredible American poet called Ella Wheeler Wilcox when she said, "To sin by silence when we should protest makes cowards out of men." I wasn't prepared to be a coward, and I told him frankly that the specialty needed to change, but it didn't. So let's move on. And you might think it's odd that I think about this notion of privilege in relation to dying, but there is privilege in terms of having dignity in death, in having one's distressing symptoms resolved by highly skilled clinicians, by talking through all the detritus that comes with us to that moment in death, and also caring for the families who surround those individuals during that journey and then through into bereavement. What do I mean by this word privilege? Well, it has its roots in Latin, and I'm thinking here of the word privilegium, which is associated with benefit enjoyed by an individual or group beyond what's available to others. You know, I might have gone to a sink school in inner London. It was a disastrous education, but I came with other kind of hidden virtues and privileges that I'm only now beginning to be aware of. Peggy McIntosh is a very interesting medical sociologist, a feminist, and she talks about her invisible backpack of privilege. And she says that when she opens the lid of her backpack and looks inside, she can count about 28 different kinds of privilege that she's aware of. So, for example, she says that if she turns on the television or opens the front page of a newspaper, she sees people who mostly look like her, if that makes sense to you. Sometimes it's really worthwhile to go back through the back catalogues of journals to read those wonderful things called editorials, where people have really focused their energy on a particular issue. We often miss them, but I think there are some real gems in them. I'm really interested in focusing on David Roy. He was a bioethicist and the editor of the Journal of Palliative Medicine. This is something that he wrote 20 years ago, and I think it's really poignant that we focus on this. He said there are probably not too many of us working in this well-organized hospices and palliative care programs who have much extensive first-hand experience of how the poorest of the poor and those who are socially utterly marginalized live and die. How do the poorest of the poor die? Do we really want to know? That knowledge might be very disturbing, loaded as it might imply that we need to do something. And I think we do need to do something. I don't want to go back to that previous narrative where we push it into the long grass or into the corner of the room, because these are moments in life that can't be replayed. So there are a number of inconvenient truths that I want to shed light on over the next few minutes. My old colleague, close friend, Catherine Sleeman, professor at the Cicely Saunders Institute, gave a great TED talk a few years ago, which you can watch on YouTube, where she said despite the best efforts of clinicians and scientists globally, mortality is fixed firmly at 100%. But it's another inconvenient truth that what happens in life is often mirrored in death. Death doesn't discriminate, but the manner in which we die and the manner in which we grieve will be discriminated across a number of really interesting parameters, and I just want to focus on ethnicity, and I'm going to pick a few examples out from a very deep bucket. Let's start off with pain. We know that pain is a really common symptom associated with advanced diseases. It goes up to about 90% plus in the most advanced stages of cancer. I think it was Albert Schweitzer who suggested that pain is a worse enemy than death itself. We conducted a systematic review a number of years ago to examine the literature in relation to the assessment and management of pain across different ethnic groups in high development index English-speaking countries. And what we discovered was that there were certainly site-specific examples in the States where patients from minoritized communities, typically African-American or Hispanic, were getting lower doses of morphine compared to their white counterparts. Really interesting really interesting here. Why is this happening? What's happening in those encounters? Very little research had taken place in the United Kingdom. We knew from the National Cancer Patient Experience Survey that patients from minority ethnic communities were typically less satisfied with the way in which their pain was being managed. So we got money from the National Institute for Health Research. This was with colleagues at the Cicely Saunders Institute and the University of Cambridge to conduct for the first time in the United Kingdom a nationwide observational cohort study of around, 250,000 patients using 4 million prescriptions from 2011 to 2020. And we were focusing on the last 3 months of life to examine the hypothesis that there may be some noise there in relation to the number of prescriptions that different ethnic groups might be receiving at that interesting moment in their lives. So we identified, we didn't want to, but we did, an ethnicity pain gap. And here you can see, whilst we adjusted for many other factors, the adjusted relative rates of prescribing were less for minority ethnic communities compared to the reference population. We also looked at the morphine milligram equivalence, and this was a complicated convolution of working out all the different doses of morphine, and then we identified that not only were they getting fewer prescriptions, they were getting less medication. I think I said earlier that pain's a really distressing symptom, if you remember. How can this be happening? This raises more questions than it does answers. We don't know what's happening in those clinical encounters. We don't know whether those patients were taking that medicine, and we don't know to what effect. But what we do need to do is to understand who's doing the pain talk. So I have a PhD student in the moment who's doing just that in order to co-develop, to co-design cancer pain education resources that patients from minority ethnic communities can use so they have greater agency and empowerment to tell clinicians, I'm in pain, help. This is an interesting study. This is a study that focused on preferences for where people wanted to die across a number of European countries. The most preferred locations were home, followed closely by hospice. The least preferred locations were institutions, for example, hospitals and care homes. Let's go back in the back catalogue to find out what they were doing at St. Christopher's. This game, back to Sicily, always go back to, regress to the mean in terms of what did Sicily say. No hospice care, there will be no barriers of race, colour and creed, but what's the material reality of what's been going on? This is a study that took place in the States, not the United Kingdom. Close to 200,000 patients. And what we can see here is that when they examine socio-demographic characteristics in relation to dying in hospice, patients from minority ethnic communities, over time, no regression to the mean here, there were consistent inconsistencies in relation to where they were dying. Less likely to die in hospice. I did work with colleagues at King's, where we examined 94,000 cancer deaths across London over a 10-year period using death registration data. We had to focus on first-generation migrants because death registration data only records country of birth and place of birth. That changed during the pandemic when we realized fast and furiously that patients from minority ethnic communities were dying disproportionately. So we had to rejig the way that we were thinking about this. So back to the plot. What did we discover? Here again, we discovered that if you came from a minority ethnic community, compared to the reference population, you were less likely to die in hospice, the second most preferred location to die, and more likely to die in a hospital. Now, we don't know from the death data where these people wanted to die. But we do know from other studies that when we've spoken to carers and also patients from the British Asian community and the British Afro-Caribbean community, they do want to die at home. So shame on us. The pandemic was associated with seismic activity across a number of different areas. And we wanted to understand the relationship between palliative care and the pandemic. And my colleague Sabrina Bajwa, amongst others, put together a survey. This was the Koffman survey, where we asked a number of really interesting questions associated with how services in the United Kingdom were caring, generally for people who were dying with COVID or other illnesses during the pandemic. And we introduced some questions that we thought would be relevant to tick our box around disadvantaged dying. Were there any differences in terms of supporting patients from minority ethnic communities? Were there issues that affected them particularly? And what we discovered was that there was a very deficit-laden model in relation to how care was being delivered to minority ethnic communities. They have different expectations. They are misunderstanding about the role of palliative care. Some of the areas we work in have always been difficult to really access. Some families are now closing their doors on us, still trying in the same way. We haven't changed our approach. You know, this speaks volumes in terms of a very deficit, judgmental way of understanding how the specialty essentially is not thinking introspectively about how it might need to change. Now, I have paid into that heuristic historically. And it was interesting to fall on my sword a few years ago in terms of, oh, I kind of got it wrong. I did work in North London and also in Canada to understand awareness of palliative care and related to palliative care and related services. And we discovered that people from poor backgrounds were typically 8 times less likely to understand what palliative care was. People from minoritized communities were also less likely, but if you think about that notion of intersection here, probably the same, they were always less likely to be aware of, no knowledge of. And when I examined the broader literature, we think here of Katrina Malan's systematic review on bereavement services, again, it's a very deficit-laden model of how we interpret critical questions. Lack of awareness, lack of awareness, lack of awareness. It's saying something rather than where do we need to change? So, with all of that, Jamila Hussain, Sabrina Bajwa, and myself wrote an editorial on palliative medicine that went viral. I mean, I tweeted it, and then I thought, my God, this has got a life of its own. And I take my hat off for Catherine Walsh for permitting us to write an editorial which stated explicitly that there were instances where palliative care was, and I'm guarded now, inadvertently racist. I don't think people get up in the morning to deliberately be racist. We made a number of suggestions, but we also made one that needed to focus on doing better science, which is why we then conducted a systematic review. We found 109 papers, and there were several key issues that came out from that review. Firstly, the questions were largely contrived by people who look like me. The methods were contrived by people who look like me. The way in which we reported our findings lacked precision and also lacked that thing called respect. So it was on the back of that I went to the Medical Research Council. I got a grant through the Better Guidance, Better Methods stream to undertake a modified Delphi where we would develop principles in concert with the communities we wanted to serve that would guide how we could better do research in future, with a focus on minoritized communities specifically, but more generally. We didn't have that compass point before. We've got 13 principles. This is currently being written up for palliative medicine. Let's look at the workforce. And when I've done this with British audiences before, I say, look around the room. Who's to your left and to your right? Do they look like you? And then, do you look like the patients you should be caring for? The specialty doesn't look like the populations we serve. There are very few chief executives of British hospices who come from minority ethnic communities. How do we change that narrative? I did some work for Marie Curie and Public Health England a number of years ago, where I conducted a systematic review and a population-based needs assessment and came up with 15 recommendations. Great recommendations, I thought at the time. Nothing has changed. Nothing. And I think the general tone of these recommendations was that if we spoke louder, they would hear. So I think we need a new broom or new bed linen in relation to what we need to do to change. So we go back to those words around dying with dignity and privilege, the privilege of dying a dignified death. And I come to these two issues around cultural humility, which is having, excuse my French, the balls to say, I know nothing about you. Tell me what's important to you at this really important moment in your life. Or cultural safety. I don't like the kind of cultural competency type words. Cultural safety is really meaningful because it implies that we need to do something. Can it be safe to underprescribe medication that we know makes a difference? Opioids are a quality indicator for end-of-life care. Can it be safe not to talk about ceilings of care or advanced care planning or preferences for where people want to die? Can it be safe to provide inequitable bereavement support when we know that there is a train crash when things go south in relation to complicated or prolonged grief? So we wrote an editorial a while back, And we suggested in this editorial that we needed a root and branch approach to completely rebuild the specialty and the way in which we were doing research. I think the first part of a problem is admitting you've got one. And I think we have a problem. But I think there are people in this audience here today who possibly want the appetite or have the appetite to change. So, go back to another editorial. This is a great one from Sicily. Care must reach for most hidden places. And I think in this room, people will come with a tea light to illuminate some of those darker corners where we can do work which matters most to people. Thank you very much indeed.
Thank you so much, Jonathan. Just fascinating talk. Thank you. If we could open it up to the floor, if anybody has any questions. Can you see any? Sorry?
It's okay, you don't have to answer one.
One here in the front, there's some microphones going around. We'll take this one first and then we'll come to you.
Yeah, can I? Thank you for your really interesting and inspiring, shocking talk. I was wondering, do you have any ideas or data on the pediatrics part? I'm afraid it's quite the same, but do you know anything?
No, and there must be, and I'm sorry that I've not filled that space yet. There's much more work to be done. Slowly but surely. Join me on that journey.
Yeah, I'm very willing. Thank you.
We have another question down here in the front. If we could bring a microphone down to here.
Yes, thank you very much. I may have missed some, but I'm wondering about socioeconomic factors and educational level in this most recent research you have done in relation to ethnic background, because I guess in the UK, for example, you have some subset of ethnically non-UK citizens that are highly educated.
Sure, and I think you raise a really interesting point. I mean, we do talk about this notion of intersectionality. I mean, it's not... Regrettably, many people who come from minority ethnic communities also inhabit geographical areas in the United Kingdom that are associated with material deprivation as well. In all the studies that I've conducted, I'm thinking particularly of the latest opioid study, we factored in what's known as the index of multiple deprivation, and we've adjusted for that. But it is obviously a factor which will influence the way in which services are used, certainly where they're located. You know, typically hospices are located in lovely areas in the United Kingdom. They're not in some of the grittier parts of towns that I've worked in historically. But it's an important factor.
Thank you.
Thank you. I'm just going to abuse my privilege and ask a question myself. So we've kind of acknowledged that some of this really important work into inequalities is lacking in the paediatric palliative care population. So just be interested if you could share some of your views as to what are the challenges, or perhaps some kind of tips for overcoming some of the challenges in conducting research with so-called hard-to-reach populations.
And you've also fallen into that trap of using hard to reach. Okay, you know, it's only until relatively recently that the funding councils have been interested in focusing on disenfranchised population groups, people who have historically been underserved and under-researched. You know, there's been more of a furore, there's been more motion over the last several years for minority communities. I'm riding that wave for as long as I can. I think we need people who will join forces with us because we've learned a lot about the narrative, which may be relevant to pediatrics. Certainly if we're thinking about carers, for example. I think there's a great space to fill, and there's an appetite, certainly from researchers who have cut their teeth in terms of understanding how to do this work and engage in local communities, which is so important in terms of co-designing studies and grounding those studies in the lived realities of the people who may merit from what we find. Thank you very much.
Thank you very much.
Thank you so much, Jonathan. To continue this discussion, I am so honored to be welcoming my colleague and dear friend, Joe Khoury. He is a family physician and an adult and pediatric palliative care specialist. He's the head of the Hauteville Hospital in France and the education program coordinator at Balsam, the Lebanese Center for Palliative Care. He's a member of the Scientific Council of the French Society of Palliative Care, and he is also an incredible human and speaker, no pressure. And we asked for his fun fact, and his is that he collects a stuffed animal from everywhere he travels to, which is lovely. Do you have one from Rome yet? No? Okay. And so to continue this discussion of diversity, equity, and inclusion in pediatric palliative care, please welcome Dr. Joe Khoury, who will be talking about honoring the diverse cultural and religious practices. Oh, we missed. That was that. Okay.
Thank you, Liz. It's really an honor to be standing here today to talk about something that's not just about health, but also about being human, and especially with everything that's happening in the world currently and in my part of the world and in my country. And palliative care is about this. It's where medicine meets humanity, where medicine meets emotions, cultures, religions. And what I would like to do is try to discuss how we can navigate the complexities of culture and religion in order to provide care that is more respectful, more compassionate, and ultimately more effective. So let me start with a case from my early times as a palliative care physician in Lebanon. In fact, it was my second patient ever. And so she was an elderly woman with cancer, and her daughters had decided not to tell her about her diagnosis, which is something that is quite common in Lebanon because culturally, we think that having such discussions can harm the people. And so as I was visiting them for the first time at home, one of the daughters was standing at the door, waving at me frantically from behind to make sure that I would not say anything. And the woman looks at me with a smile, and she says, "So doctor, I have cancer and I'm gonna die soon, right?" So she knew. And not only did she know, she was ready to talk about it while her daughters were not. And so this experience and many others later on made me wonder, is it really culture that makes us avoid these conversations, or is it something else? And then, what's culture anyway? Like, what defines what's cultural and what's not cultural? So let's take a look at the definition of culture. UNESCO defines culture as a set of distinctive spiritual, material, intellectual, emotional features of a society, And it encompasses art, literature, lifestyles, ways of living together, value systems, traditions, beliefs. I don't know about you, but this does not help me understand when I see a behavior if it's cultural or not. What I know is that when we think about culture, we tend to see it as something that is static, that does not change. You know, it's their culture. While in fact, culture is fluid. It can change, and it changes with time, with major historical events, even with personal experiences. If we talk about me, so I'm Lebanese, I'm Christian from the Maronite community. I was born and raised in a big city in Beirut. I was surrounded by friends from the Muslim and Druze communities. I listened to Fayrouz, but I also love Céline Dion. I went to a French-speaking school and then to a French-speaking university where I studied in American textbooks. And then I traveled to the US for 6 months to finish my studies. And I lived there with a family from the Protestant faith. And by the way, this is where I discovered their version of macaroni and cheese. And trust me, as Italians, you do not want to try that. So later on, I moved to France, and now I live in a small village in the mountains, so that's also a big change for me. And I work at the local hospital there. So what's my culture? It's a tapestry. It's a mix of all of these experiences. And it's rich, it's complex, and it's unique. It's unique to me. Can it be compared to my cousins who never left Lebanon, who went to a typical Lebanese school and always lived in his village? No, of course not. So it cannot be standardized or compared to anyone else, even from the same country. And similarly, if we look at a higher level, a bigger picture, even in societies, we have seen how cultures can change. If we look at attitudes toward healthcare, in the US, for example, in the 1960s, 90% of doctors did not tell their patients about their cancer diagnosis. In the 1970s, so 10 years later, the majority of them supported full disclosure. And today, 98% of oncologists consider it as their moral duty to say the truth. So that's a huge shift. And it happened over a few decades. And it happened because in the meantime, there were studies that were published that showed that withholding truth, in fact, increased distress and increased fear and anxiety in people. In Italy, traditionally, autonomy and taking decisions alone used to be seen as a sign of isolation. And traditionally, doctors used to prefer speaking with families instead of speaking with patients. Today, this has changed, and informed consent is a legal and an ethical obligation in Italy. Even in Lebanon, where we think it's a more conservative part of the world, in 1998, 47% of doctors did not tell their patients about their cancer. In 2007, 99% of them supported full disclosure, although it's still common not to say everything and to go to the families first. But we also have data from patients in Lebanon who today consider it as their right to know everything, to know the truth about their diseases. So my first message here is that attitudes, cultural attitudes and beliefs, like any attitude or belief, is not set in stone. It can change. And so this is maybe why we should not make assumptions too. And my second message will be that because we are all humans, we share more similarities than differences. Let's take a look at this. So through my travels, I've often heard many variations of the phrase, in my culture, we don't talk about death. And I heard this coming from physicians and from patients from countries like Nigeria, Morocco, Uzbekistan, Lebanon, and even some parts of Europe like Serbia and Czech Republic. And so it also makes me wonder, is it really cultural, or is it something that is more universal, like some fears that may be shared across all societies? And I can take two examples. One about physicians and healthcare workers first. So studies show us that, for example, 50% of pediatric oncologists in Pakistan consider, or they view their patients' impending death as a personal failure. They're uncomfortable facing these situations. In Korea, a survey showed that physicians also feel uncomfortable, distressed, and unprepared when they need to break bad news, because they feel that they are harming the patients and they are not fulfilling their duty of promoting good health. Even in China we have both sides of the story, because there's a study that showed that physicians don't like to tell the truth while patients want to hear the truth and they're waiting for it. If we go to the other level, which is the society's level and the patients' and families' levels, another universal fear is the fear of death. And there are many books and articles that have been written about this. The fear of death is a fundamental part of the human experience, and it's shared across all societies. And in fact, culture is a way that human beings have developed to cope with that fear, to build something around it, to be able to live with it. All of those rituals, all of those traditions that we have around death are here to make us feel a little bit better about it. And so, let me be clear. I'm not saying that there are no differences. Cultural differences do exist. And acknowledging them is necessary, and neglecting them can lead to profound suffering. What I'm trying to say is that there may be some common ground, some common fears, some common concepts that we can uncover behind what we see in order to find a shared space where we can better communicate with others. And the danger when we think about culture is over-attributing everything to culture. So I once saw a family in France who was from Sri Lanka, and the healthcare team thought that they did not discuss their child's prognosis because of their cultural beliefs, because it was in their culture. So they even stopped trying. And in fact, it turned out that they were only protecting the grandmother, who was emotionally fragile. And one day when she was not there, the discussion happened and it went very smoothly. And so it was not cultural, it was personal, it was familial, and it really struck me how easy it can be to just categorize people based on their appearance or nationality or religion. So we need to be conscious about that too. So, okay, there are differences, there are similarities. We may be able to find some common ground. How do we approach all of this compared to our own culture? You will hear about an approach, a concept called cultural relativism that encourages us to view other cultures without comparing to ours, without believing that there's no culture that is superior to another. So, for example, an answer to a family who's asking not to use morphine and to use traditional medicine for their child, in that case, would be, okay, we will integrate your traditional medicine into our care plan, so we will prescribe lower doses of morphine, although we are not sure about the results. But if it's important to you, I'm not here to judge, so I'm going to try. Another concept is ethical relativism that even takes things even further by considering that there are no universal ethical principles, and that even ethics can be flexible across cultures. So in that case, the answer would be, we will respect your choice to use traditional medicine, so we will not prescribe morphine, even if the child remains in pain. Because if in my culture and in my opinion, living pain-free is important and it's an obligation. It's not for you, so I'm going to do as you say. And you can already sense the ethical and challenges and dilemmas that these approaches can raise. The third approach, the third concept is ethical universalism. And in that case, we do believe that there are ethical principles that every human being on this earth should respect and should apply, and that we cannot overlook. So in that case, we would consider that living pain-free is a universal obligation, it's ethical, and the answer would be, okay, we will integrate your traditional medicine into our care plan, but because pain relief is a universal ethical duty, we will need to change our strategy if it does not work. So I'm going to do a step towards you, but I need you to do a step towards me so that we can meet in that shared space where we all agree on some universal principles. The next step in our approach to other cultures is to develop some strategies. And first, looking and seeking cultural competence. Today we have data from focus groups and from workshops that show the need and the demand of healthcare workers to learn more about other cultures so that they know how to approach them. There are publications that exist and that show that, and we need to advocate for this. We also need to remember that sometimes maybe some of the things that we have learned and that we use should be or may be contextualized depending on the situation or the country. For example, we all know and use the spikes and the nurse protocols to enhance our communication. Sometimes maybe we should look at the cultural setting and try to see what can be adjusted in this situation. And for example, in Morocco, key phrases have been translated into the local dialect by a focus group there in order to help physicians choose the right words to communicate in this particular setting. Next, we need to build trust. And to do that, we need open communication. We need to demonstrate interest. I want to know more about your culture. I want to know more about your belief. Please tell me more. We can just name the emotion to bring back the person to the center of the stage instead of that, what I call the cultural wall that sometimes people stand behind. By saying, for example, I hear your beliefs and I respect them, but I can also sense how the situation is frightening to you as a person. So can we talk about this too? And this can sometimes change everything. We need to express commitment to care. I want to provide the best care possible to your child, and I want to do it while respecting your values and your traditions. We can also, if we want to try to apply some of the concepts that we saw earlier, that cultural relativism, ethical universalism, remember that in many, many countries, for example, families operate as a care management group instead of an individual person. And being able to say, okay, I'm going to communicate with all of you as a group, but I cannot lie to the patient. So if they ask a question, I will have to answer, but I will do it in a culturally sensitive way. I will do it by respecting what I learned from you and what you told me about your habits and your traditions. And finally, a third strategy. And this table is just to say that there are also studies and there are tables and articles that exist, resources that you can look for that show some phrases and some communication tools that can be helpful in these situations. And so finally, the third strategy is to remember to just ask about rituals and try to incorporate them. And sometimes it can be very easy. So there's a family at my hospital who used to play prayers on their phone every time they came to visit their loved one. And on the day that he became unconscious and he was approaching death, the nurses from the team brought an iPad to the room, and they started streaming the Muslim prayers from YouTube, and they let it there. And I cannot describe how grateful the family was when they came back the next day and they saw that. And they later shared that just seeing this iPad in the room made them reassured that their loved one was getting care that was respectful and compassionate. So ask about the religious rituals. Again, there are resources that compare rituals around the world and around religions, and see what can be done to ease this difficult situation on the patients and their families. And so to conclude, let us look at the case of Maya, who is a 9-year-old girl from a Buddhist family. She has brain cancer, and the family tells the team that, according to their faith, Maya needs to stay awake and fully conscious to the last minute, because this is very important to help the transition and her reincarnation process. So she cannot be sedated at the end of life. Of course, this is a challenge to the healthcare team, because they would like to make sure that she is comfortable, and they would like to use some sedative meditations. So what can they do in that situation to try to incorporate those demands and at the same time be more respectful of their own ethics? So first, the team holds an interdisciplinary team meeting, and they invite a Buddhist monk to seek cultural competence and ask about the rituals and the importance of being fully conscious at the time of death in the Buddhist faith. They also agree to move Maya's bed outside of her room twice a day so that family can light incense and do their prayers, because of course it was not possible in the room when there's safety regulations and oxygen equipments and all of that. They allow chants at the bedside. They even join the family for some meditation from time to time, and they change the focus of their communication to focus really on symptom relief and on minimizing suffering, instead of just explaining the scientific and the medical benefits of sedation. They agree to use smaller doses of medication. In parallel, they increase the non-pharmacological therapies, and they explain that if this strategy does not work, they will have to change it, because they need to make sure that Maya is comfortable. And finally, when Maya dies, they delay any intervention in the room for 6 hours to allow the family to do their rituals, because they said that it was important for her soul to transition peacefully. So Maya's case shows us what's possible when we decide to integrate culture and religious rituals into our care. And in a world that is increasingly diverse and even enriched today with stories from refugees and migrants, it's even more important to remember to respect this diversity if what we are seeking is giving the best care possible to everyone. So I leave you with a quote from one of my patients who once told me, "Doctor, I don't need you to understand everything about my culture, but I need you to respect it." And this is what we're here for. We're here to listen, to respect, and to honor the values of the families that we serve. So let us embrace the diversity and the richness of the cultures that we encounter in order to make sure that we offer the best care possible to every child everywhere in the world. And the best care possible is care that is rooted in humanity, in respect, and in compassion. Thank you.
taking a moment. I hope you're taking a moment too. Thank you, Joe. And we're open to any questions or comments from the group. Oh, we have one. Okay, good.
Joe, thank you for that wonderful presentation. You pricked our hearts and minds. One observation I would make is that there is a certain term that we use, perhaps incorrectly, perhaps loosely, in our respect or disrespect of persons from varied places, differences, people that are different from whoever I am. And that's the term vulnerable. We oftentimes refer to the pediatric population as a vulnerable population, but then we see some who are more vulnerable than others. And vulnerability can be a label. There are physical, socioeconomic, other sources of vulnerability, but there's also emotional vulnerability, our ability to cope. And I wonder sometimes if we as clinicians fall victim to our emotional vulnerability and to our cognitive vulnerability. I don't know everything, but I'm afraid to admit that. Could you perhaps respond?
No, I don't have anything more to add to what you said. I do think, as I gave the example of hiding behind culture because we have our own insecurities as physicians and as healthcare workers, I think that you hit the point too. Projecting our insecurities on the people that we serve is a quite common mechanism, I think, and just being able to realize that and to be conscious, more conscious about this is complicated, and it takes some thinking, and it takes some interactions with others to really be able to understand that, yes, maybe I'm labeling, or we are labeling people because we don't know, or because we feel insecure, or because we feel helpless sometimes, and that what should be done is maybe not going and trying to change those people, but trying to start change in ourselves. But I don't have the answer either, because it's such a complicated feeling and subject. Yeah.
Joe, over here. What a spectacular talk. Thank you so much. I'm reflecting on my own efforts to, just sort of embrace the values and the approach that you put forward, which I think is absolutely best practices. And I know that in many ways, as pediatric palliative care clinicians, we may have more, let's say, expertise in this area than our colleagues, although many others do as well. I would say how do we manage, though, our own, even if we try on the surface to be incredibly respectful and compassionate, when we have deep-rooted differences in our cultures. And an example that comes to my mind, some may know that I'm rather a feminist. And when I'm faced with a very paternalistic approach within a family, it's really, really challenging for me as a clinician. So I'm curious, how do we manage our own distress around when our values are really in contrast?
So again, there's no universal answer, I think. From my perspective and from my experience, because yes, I did encounter some, and it wasn't even me, so I see it as a team, the whole team being uncomfortable because of some differences with other people. And for me, the basic answer is just focusing on the communication and on what we can find, maybe trying to put aside what really shocks us in those differences. And because what we want to do is to provide care. And sometimes being able to look past those differences can be difficult. So can we shift our attention to something else that we are able to do, and where, so it's all about trying to find that common space that maybe is not the most evident one, the one that we would hope to find, but trying to find that tiny space that maybe we can agree on and try to build upon it. It's complicated, it's difficult, and we have had in the team times where we had some people had to just take a step back and say, I'm not able to deal with that. Is someone else ready to please care for this patient instead of me? And that can also be a strategy to say, I want to avoid conflict. I want to make sure that the patient is getting the care that he needs to get. If I'm not able to do that, maybe I should just leave the space for someone else who maybe has other resources or other experiences. So, voila.
Are there any other questions? Yeah.
Thank you. As I think you appreciate, everybody thought that was a very good talk. And there was a reflection clearly on patient and family culture, be that what it may, and then on our personal beliefs. And I wonder if you could comment on facing cultural challenges with the intermediary, which may be the primary team. So it wouldn't be uncommon for me to encounter, say, an oncologist who says, like, I'm not comfortable talking about this, and therefore I'm not going there, and I'm not referring to palliative care. Or perhaps a social worker that says, I've talked to them, they don't want anything, they're not spiritual, so don't ask, because I've already done it. And there's this barrier to actually getting in. The second level to that is where our institutions, so particularly, I come from Canada, very multicultural, but the power balance in Canada resides with Western settlers, and the ethics of our healthcare system are based on colonialist settler values, which isn't representative of our patient population. And some clinicians can fall back on standards of practice, but standard of practice that were developed by old white men in 1920, right? Like, so I wonder if you could comment on culture in the intermediary.
Well, I think this is why we're talking about this subject today. It's because it's so rooted in our thinking, and like in med school we have learned about principles, and this is standards of care, and this is what should be done, and having the reflection doesn't come intuitively. So I think the first step is just starting the discussion. I don't have a magical solution. I know that going back, so as you said, when a social worker says, okay, I asked the question, they don't want to talk about it, trying another approach, just asking the question differently, or coming from another side of the topic can help. And this is what I do. Usually, when I visit the patient the next day, I try to have the conversation again, but by focusing on something else that maybe we have noticed is important for them, and then building upon that. But yeah, I think the biggest challenge is challenging our colleagues, and this will start by just realizing that we need to talk about it and advocating to include this in our medical practice, because as I said, we haven't been trained about that, and there is a need and there is a demand in many places today.
in the interest of transitioning over to our next speaker, I just wanted to thank you again, Joe.
Thank you. So it gives me great pleasure to introduce our final speaker for this afternoon's plenary, Professor Julia Downing. Julia is a nurse by background and Chief Executive of the International Children's Palliative Care Network, and she spent many years working in Uganda and internationally and advocating for children's palliative care across the world. So our fun fact that I learnt about Julia today was that she got married during the pandemic in a small ceremony in Kent, which was live streamed to many friends and family across the world. That's fun fact. Thank you. Go ahead, you take the floor, Julia.
Thank you very much. And I'm taking advantage of having been liberated from standing behind the podium. So, what a session we've had. We've talked about privilege. We've talked about diversity. We've talked about racism. We've talked about culture. We've talked about religion. And I want to talk now for the rest of the session around equity. Equity and paediatric palliative care in low and middle income countries. Now you might be wondering, and I know that I'm standing here with that privilege that Jonathan talked about. There is no equity. Some of my colleagues who would have loved to have been here aren't here. They couldn't get visas. Or maybe it's not that they just couldn't get the visa, they couldn't get the appointment to get the visa until next year. There is inequity in paediatric palliative care. 2 children. The first one, this young girl, she was the first child I ever cared for who had cancer and who died. She was from a country in Eastern Europe. This was nearly 30 years ago. She was from a country in Eastern Europe. She could not get access to cancer treatment. She could not get access to palliative care. Her parents sold everything to bring her to the UK, where treatment was given. Sadly, she still died. When we spoke to her, what did she want? She wanted to be at home. She wanted to die at home. She wanted to be with her siblings, with her friends back home. There was no equity. There was no access then. This other young boy called Dowdy, he was one of the first children I cared for when I moved to Uganda back in 2001. We found him on a rubbish dump. The other side of his face was eaten by maggots. He'd just been abandoned. He was unloved, uncared for. Hopefully, we were able to care for him in his last few months. He had HIV. And it was with great delight when we eventually saw him smile. There was no equity in access. This is a hospital in Rwanda, Siyashuka. It's the University Hospital of Kigali. And I heard one of the most powerful stories about children's palliative care here in Rwanda. Not in the UK, not in America, but here in Uganda. We've done some training, we've done a big project on palliative care, including children's palliative care. And we had an evaluation. Some of you might have heard me say this before. We had an evaluation, we had an independent person come to Rwanda. She asked the head nurse on the pediatric ward, what difference has pediatric palliative care made? And this head nurse said, listen. So we listened. We couldn't hear anything. The evaluator said to the nurse, I can't hear anything. And that nurse said, no. Before we knew about palliative care, we didn't know how to communicate. We didn't know how to manage pain. All of our children were crying. Now, they're not crying anymore. That was the difference that palliative care made. The difference that we can make in the lives of children and families wherever they are. So important. And we know that there are millions of children around the world who are facing needless suffering because they can't access palliative care, them and their families. We also know the greatest need is in low and middle income countries. There's no option. We must help improve palliative care for children around the world. We need to look at equity around the world. We need to make sure that there is more equity within children's palliative care. So let's just think about equity. It's not about equality. It's not about giving each one of us the same. It's about looking at our different circumstances, allocating the resources that are needed and the opportunities that are needed to reach equal outcomes. And I'm sure you've all seen these pictures before, but I like that demonstration. The World Health Organization talk about equity as the absence of avoidable or remediable differences among groups of people. We need to do something. We need to do things differently. We need to make that change. Health equity is when everyone has the opportunity to be as healthy as possible. That means for children's palliative care that every child, regardless of where they live, has access to palliative care, so that they, within the constraints of their condition, can have the best, be as healthy as possible, can have the best options. And I believe, and I know many of us believe, and at ICPCN we believe that children's palliative care should be available for all children, regardless of what condition they have, what religion they are, what their cultural background is, where they live, how old they are. It should be, and it must be available. And we're not going to stop until that is the case. So we're going to think about equity and the delivery of paediatric palliative care. And I'm going to start with learning from yesterday and living today, and then we'll look at shaping the future. But we have to remember that we work within a wider context, and there is inequity in healthcare generally. This is looking at under 5 mortality, and the green line at the bottom is the highest income countries, and the red line at the top is the poorest. That says it all. And that is the environment in which we are working. We know that within the African region, under 5 mortality is so much higher. So on average, it's 70 per 1,000 live births. Here in Italy, it's 2.6 per 1,000 live births. We have to think about that wider change. How can we not only affect change within palliative care, within paediatric palliative care, but within the wider healthcare? And this is just a picture that shows it starkly as to where the highest levels of under 5 mortality are. But the World Economic Forum said there are inequities. There are too many people around the world lack access to basic health care. There are deep-seated social determinants of health, poverty, discrimination, gender inequity. And I was also thinking in that last question, what about the culture of our different professions? As a nurse, I have been in situations where doctors have literally turned their back on me because I'm a nurse. What about these inequities within our health professions? We also have in low middle income countries the dual epidemic. We have infectious diseases and now an increase in non-communicable diseases. There are often weak health systems, which might be weakened even more so by armed conflict, by humanitarian crisis, by floods, by climate change. All of this impacts how we provide paediatric palliative care. So there are underlying social factors that we are working within, but that's not an excuse for us. We need to address issues of inequity. So what about in children's palliative care? Well, the study that we did was published back in 2017 with UNICEF and ICPCN, showed that there were over 21 million children who need access to palliative care. And the estimates are that less than 10%, between 5 and 10% of children can access it. So if there's 21 million children and less than 10% are accessing it, that's over 19 million children around the world and their families who can't access palliative care. But we also know from work done on the Lancet Commission report that access to palliative care is a global health and equity imperative. We have to do something about it. There must be essential palliative care available for all. Adults, children, babies, for all. Public financing is important. We must look at cost-effective ways of providing care. We need to take action together, and there needs to be better evidence and priority setting. But they also pointed out to us that over 98% of those children that need palliative care live in low and middle income countries. But in low income countries, over 30% of deaths associated with serious health-related suffering in children, so childhood deaths associated with serious health-related suffering, over 30% were due to that, whereas in high-income countries, it was just 1%. So the need for pediatric palliative care in low-income countries is great. They also worked out that at best international prices, cost for opioid analgesia in all children needing palliative care in low-income countries, just for the medication, was only $1 million. Now, for many of us, that sounds like a lot of money, but within the overall health budget, that is nothing. We should be acting. We need to make that difference. We know there are challenges to the development of pediatric palliative care in low-middle-income countries. For example, in Uganda, 80% of children with cancer will present with advanced disease. So even if cure was possible, it's not possible by the time they present. There are uneven distribution of services. There used to be one place in the country where children could get access to treatment for cancer. There's now 2 or 3, but there's still uneven access. The expense of going to the other side of the country, one of your parents will have to stop work to care for the child. It's just immense, and we know that having a child needing palliative care in a low-income country will put you into a spiral of debt and poverty. There's a lack of awareness around what children's palliative care is. There's a lack of technical expertise and skills. A lack of recognition of the need for pediatric palliative care. One Minister of Health said to me, rather condescendingly, "Julia, we don't need palliative care for children. Our children don't die." That was a Minister for Health. We did what Joanne called a quick and dirty study and showed him that, sadly, children did die and they did need palliative care. There's a lack of policy. There's a lack of access to education, treatment, trained professionals, medicines, and we'll mention that again a bit later. Palliative care isn't integrated into our health services. Now, in many high-income countries, it isn't as well, but it isn't integrated within the systems. There are a lack of resources, and the humanitarian and armed conflict settings, the impact of that in already low and middle-income countries is just so great. You may have seen this. This was in the Lancet Commission report. This is morphine equivalent, availability of morphine equivalent. What we see here is the dual pandemic. We see countries like America, Canada, Australia having much more morphine than morphine equivalent than they need due to addiction, due to abuse. But then we see most low middle income countries are not there because they don't have access. So we have a challenge. We have some countries trying to limit access and others just trying to get access. The first time I went on a home visit in Uganda back in 2001, all we had was paracetamol. We had nothing else to give. We need to change that. We need to make a difference. And you can see here, this is from a study looking at access, that there's many countries that don't have access to the medicines they need to manage pain in children. What about training? Much of the training is focused in high-income countries. And what does that mean in terms of even now, when things can be done virtually, what about the cost of that training? How do we make sure training is provided in the language that is needed and in an affordable way to train people within low and middle income countries to develop children's palliative care? How can we support those? There are many here today who are doing amazing education work. How do we support them to expand, to increase and reach more people? This is a map which you saw yesterday from Anna, looking at the development of children's palliative care. Those countries in white, there's still either no known children's palliative care or very limited access. Many of those countries are in low-income countries. We want the whole world to be dark green. We have a long way to go. And just as a pictorial representation, up on the left there, those are high-income countries. So the red ones are the least developed in terms of children's palliative care. The green are the most developed. That is over a 20-year period in high-income countries. This is low-income countries. The upper and middle and lower middle-income countries don't even have one country that is reaching that higher level. We've got to do something about it. We need to make a change. So how do we shape the future? We have changing demographics, and we have more children living longer. So how do we cope with that? How do we make sure that that fits within our systems? How do we make sure that there is equity in access for all those children? There are various models for development, and the WHO conceptual model, which is the house model here, talks about the things that are needed in order for the development of palliative care. We need to have empowered communities. We need to have policy. We need to have the evidence base and research. But we need access to medicines. We need access to education and training. We need integration of services. But above all, we need to make sure that the needs of the children and their families that we are caring for in whichever country that we live, in whichever part of that country we live, that their needs are being met. So we can shape the future, and we need to do something different. Jonathan's already talked about looking at how we do things. What do we need to do differently? There is lots still to do. We know how to provide. We know the basics of how to provide pediatric palliative care. How can we reduce that inequity? But it's not just about resources. I was with a young child in an African country. It wasn't Uganda at this time. It was in Ghana, and I was with this young child who got really good palliative care. I then went to a very high-income country. The children there that I was seeing were not getting good palliative care because their parents had so much money they could keep them alive on ventilators. Which was getting the best palliative care? So it's not just about financial resources, although they are important. It's about attitudes, it's about understanding, it's about philosophy. There is a commitment for palliative care from the World Health Organization, but we need to work together. But also we have that continually changing environment. We have continually moving cultures and developing culture. We need to be moving. We need to be doing something different. But things are moving. This on the left was in 2016 in Uganda. We had one radiotherapy machine. It was broken. One for the country. It served Uganda, Sudan, Rwanda, Congo, Burundi. One machine, it was broken. Now we have 3 machines for the whole country. When I think about London, how many machines are there in London? We've got to do something about this inequity. There are documents to help us. There are resources to help us. There are standards to help us. There are standards, the pediatric palliative care standards, which we talked about 2 years ago here in Rome. They talk about how do we provide pediatric palliative care in humanitarian settings. We have done work on what makes an effective pediatric palliative care program in LMICs. Clear and strong leadership, a focus on the vision, a passion for children's palliative care. There are many models, but we can't just take what works in the UK and put it in America, what works in America and put it in Lebanon, or put it in Uganda, or put it in Latin America. We have to make sure that the models are appropriate for the setting, for the culture, that they are inclusive. How do we do that? How do we ensure that that is the case? We must involve children and young people. This is a picture of Lucy Watts, who did a lot of work with the World Health Organization and was a real champion for children's palliative care. And then we have a team in Uganda of children and young people inputting into some of the research and some of the work that is being done. What is it that's important to them? What's important to somebody in a low-income country in Asia might well be different from in a low-income country in Africa, in Latin America, in Europe. What is important for the children and their families that we care for? My colleague Liz Gwither said many years ago when I first met her, we may not be rich in resources, but we are very resourceful. We can think outside the box. We try things differently. Nurse prescribing. In Uganda, we have a course for nurse prescribers so they can prescribe morphine and other medicines. If we didn't have that, there wouldn't be access to pediatric palliative care in many parts of the country. In India, they have what they call family drivers. Syringe drivers don't work there for cultural reasons, but also they don't have them. So they teach the families to give the 4-hourly dose. How can we think about what is appropriate in our culture? What works in our setting? I said strong leadership was key, and so there's a lot of work going on around the world in Uganda, but this is particularly in Southeast Asia, trying to develop leaders, trying to support, encourage, and mentor leaders, trying to support them to develop children's palliative care appropriately in their culture, in their setting, with their resources, in their health setting. Technology. We've heard this morning already about AI, but also technology. How can we support technology, use technology? I was talking to Megan this morning and how she provides virtual consultations for MSF. How do we use technology for our advantage? How can we use technology to reduce those inequities? What about research? There is more research coming out of low middle income countries, but not enough. So how can we enable people to undertake research? If you look at, and I haven't done a study, but I'm sure Richard Harding at the back could tell me, if you look at research funding, the majority of the big grants go to, in palliative care, go to high-income countries. We need to change that. We need to enable our colleagues around the world to undertake research, to try and reduce some of those inequities. So, we can inspire each other, we can encourage each other, we can learn from each other. Let's not reinvent the wheel. We don't have the time, the energy, or the resources to reinvent the wheel. And the children and their families that we're caring for don't have the time either. So let's learn from each other, let's support each other, let's work together and not compete with each other. Often we're going for the same grants, then you're competing against colleagues. How do we work together? But importantly, how do we make sure both the voice of pediatric palliative care and the voice of our colleagues from low middle income countries is heard? How many of our presentations, and I said I'm standing here from a privileged position, how many of our presentations at this conference are from our colleagues from low middle income countries? How do we work together? How do we make sure that their voice is heard? How do we make sure that we all can learn from each other? And to do that, we need to step out of our comfort zone. So are we challenging inequitable practices in global pediatric palliative care? So do we make sure in any grants that we have that actually maybe those in low middle income countries get more money because they need that to bring them, to enable them to undertake the studies? How do we make sure that we remove any barriers from collaborations? How do we remove barriers from our colleagues attending meetings like this? So how can we challenge inequitable practice? Are we respecting different cultures, different diversity? Are we respecting each other? Are we ensuring that the needs of children and their families in low middle income countries are being addressed? I've got there a box of thank you in many different languages. I stand in another privileged position. Much of scientific language is English. What does that mean for all my colleagues? What does that mean for many of us around the world? when English is the common language? How do we ensure that that isn't the case? How do we ensure that everybody has access to education in a language that they can understand? So there are many challenges. We sometimes feel we're taking 3 steps forward and 1 step back. There are issues around funding and financial sustainability. There are issues around language. There is so much to do, but we're resilient. As a pediatric palliative care community around the world, we are resilient, we are resourceful, and we need to support each other. The time is right. I just want to give you, as I close, an example. This is a project we're doing in Ghana. And we did a needs assessment on children's palliative care, and then we got a grant for 1 year to do education and training. We put in our, you know how in grants you have to say how many people you're going to reach? 200 people on our webinars. When I checked before I came, we have over 1,800 people registered for our monthly webinars. The time is right. We need to be challenging inequitable practice. We need to be looking at how things can change, how we can support our colleagues. We need to be standing up with one voice. And I know many of you took part in our Hats On for Children's Palliative Care campaign last week. Are we raising a global voice? Are we enabling the voice of those in low middle-income countries to be heard? Are we enabling processes to reduce inequities in children's palliative care? Because every child should have access to palliative care, every child and their family. And as I was preparing this, I was looking at myself, I was looking at our work, and how are we challenging inequitable access? Because if it's going to become a reality, then it's not about equality, it's about equity. The route to achieving equity will not be accomplished through treating everyone equally. It will be achieved by treating everyone equitably or justly, according to their circumstances. We have to do that. We have to reduce inequity within low middle-income countries if children like this young boy here around the world are going to have access to palliative care. Thank you.
Thank you so much, Julia. That was wonderful. We'll very briefly take an opportunity for any questions.
I told somebody earlier I was nervous, and if you can see me now, I'm actually shaking. So I was really nervous. But I just want to say, I want to thank our Young Professionals group, because they've enabled us to talk about things in this session that we haven't been talking about, and it's so important. So I want to thank you for raising these issues.
Go ahead.
While we're in moments of gratitude and just coming to the end of our time together, I just wanted to take a moment as I think about who's sitting here with us today. We are surrounded by people who have loved ones in Israel and Lebanon and the Sudan, and I'm just overwhelmed that we're all here together, and I'm just so thankful that you're all here with us, welcoming them in community and in shared humanity. So I just wanted to express gratitude for not all that you hold professionally, but also personally, from all of us. Thank you. Yeah.